Welcome to today's webinar about palliative care for chronic disease, featuring Dr. Andrew Esch. My name is Jennifer Roeder. I'm a communications consultant for APFED, and I'll be moderating today's webinar. We are pleased to have Dr. Esch join us today to share information about palliative care for chronic disease, such as eosinophilic disorders. Dr. Esch is a senior education advisor at the Center to Advance Palliative Care. As a palliative care specialist, Dr. Esch focuses on improving quality of life for patients and families living with serious illness. Welcome, Dr. Esch.
Thank you. Thank you for having me, Jennifer. It's really one of the best parts of my job, working for the Center to Advance Palliative Care, when I get to talk to patients and caregivers. So I really appreciate this opportunity, and I look forward to the next hour. And I really would encourage everybody that's on to ask questions. I'm going to leave a lot of time at the end so we can have a discussion. And really, if it's on your mind, ask it, and we'll work our way through it. So I'm going to pull up my slide deck here, and we can work through the slides that I had prepared for this. But if at any point you have a question, just put it in the chat box, and we will we'll get to it either during the talk, or we'll get to it at the end. So we're going to talk about palliative care today, and we're going to basically define what it is and who can benefit, how and well it could help you or the people that you're caring for. And we'll talk a little bit about the resources and how to get further information on palliative care as well. So palliative care is specialized medical care. So we're like any other medical subspecialty. We focus on patients that are living with serious illness. And instead of focusing on the specific, specifics medically of the illness, we really try to focus on how that illness is affecting somebody's life. So what are the symptoms they're experiencing? What are the stresses? What is that experience of living with an eosinophilic disorder? What is that impact on a patient's life? And the goal is then to improve that quality of life for the patient and for the family. So how do you do that? Well, you do it with a group of people, because we're pretty complex beings. So to think that one clinical provider like myself would be able to really understand and address everything that somebody with a chronic illness is experiencing is not realistic. So palliative care is provided by a specialty trained team of doctors, nurses, and other specialists. And oftentimes those other specialists are social workers, chaplains, sometimes depending on where you're located, pharmacists can be part of that, navigators. And that team of specialty trained clinicians work together with your other doctors to provide an extra layer of support. So we sort of sneak in that with your other doctors in the middle of that, but that's a really important thing, because communication and coordination of care is probably one of the most important parts of what we do as a palliative care team. And so, we can provide this care at any age and at any stage of a serious illness, and it can be provided along with curative or disease-directed care. So it's not an or. You don't have to give up what you're doing with any other clinicians you're seeing. It's an add-on. So public understanding of palliative care is pretty low. And so maybe we could put up the poll now, Jennifer. Would that be maybe reasonable? So I'm just going to ask everybody on the call if just to maybe respond quickly to these questions. Have you heard of palliative care before today's call? And then pick one of the answers of the second question, where we talk about the biggest challenges that you or your caregivers are facing living with the eosinophilic disorders. So we'll give it a second here. And while you're filling that out, I'll talk over this screen just a little bit. And the reason we put this public understanding of palliative care being low is that my suspicion will be that the answer to the first question will probably have more no's than yeses. So what we did with some research that we did through polling patients and families is we we gave them a definition of palliative care. We basically described it as this extra layer of support, that what we talked about in the previous screen, the extra layer of support that can be provided with curative or disease-directed care, and provided by a team of people. And once people were given that definition, 90%, greater than 90% said they were likely to consider palliative care for themselves or family or their families. 94% believe that patients should have access to palliative care at all hospitals. And 78% strongly agreed that it's important that patients and their families be educated that palliative care is available together with other curative treatment. So, you know, it is well received when people are told what it is, but the reality is, you know, the majority of people don't know what it is or make assumptions about what it is that just aren't accurate. Jennifer, the poll will stay up a little longer, or is it coming
I'm
down?
happy to go ahead and take it down.
Yeah, why don't we see what the responses were? Just curious before we move on. Okay, I'm a little surprised. So about 2/3 of you said that you had heard of palliative care before today's call. 67% versus 33% that said no, which is good. Maybe organizations like the Center of Advance Palliative Care, we've been doing our job over the years. So that's really encouraging, actually, and the first time I've done one of these where the results have been in favor of the yeses. And as far as the biggest challenges, about 75% of the people said quality of life, 83% said fatigue, you know, a little over half said pain or other symptoms, and then a small amount of people, less than 10%, said lack of support in the home. So about what I expected in question 2, not what I expected on question 1, but you know, this idea of quality of life and some of the other symptoms needing managed is pretty typical of people living with serious illnesses like eosinophilic disorders. Okay, let's see what I can do here. So why palliative care? So, I mean, those of you on the call, you know, you experience symptoms, right? Pain in joints, difficulty swallowing, all kinds of digestive issues. Some people have shortness of breath, vomiting, weight loss, poor appetite, pain, malnutrition, and dehydration. I mean, these chronic illnesses in general are filled with this sort of unrelenting sources of suffering that need to be addressed, and not addressed in a vacuum, but somebody who will really sit down and listen and fully understand the impact that the illness is having on a patient. And palliative care clinicians, this team of folks that are specialty trained, what we try to do is assess the sources of these suffering in people with diseases like eosinophilic disorders, and then closely work with them and their families to treat the issues. And even more so than treat the issues, just really first acknowledge that they're all happening at the same time, and then come up with a plan that helps someone to gain as much function and quality of life as possible while living with their illness. So again, chronic illnesses really have an impact on quality of life. And so, you know, we really work with the family and the caregiver to do what we can. I'm having trouble advancing my slides here. Okay, so some of the other benefits of palliative care for chronic illness. We talked about the reduction in suffering, helping families and caregivers understanding what to expect. Remember a couple slides back, I talked about communication and coordination of care. This is where communication comes in, talking to people about what they're listening, more so listening to what's happening, and then using what we know as clinicians about how some of these illnesses progress to help people prepare for what might be next, which that preparedness and communication enables care planning and decision making, can reduce unnecessary hospitalizations. We've been shown to do that in many illnesses, and supports caregiver health and well-being. So, you know, the caregivers are always the unsung heroes in all of this. Certainly patients suffer, and we want to do everything we can to improve that. But one thing that palliative care teams really have a full understanding of is that the illness impacts those beyond just the patient, and caregivers need support as well. So one of the things that I hope is a take home from today for everybody is this idea that palliative care is based on need and not on prognosis. You don't have to be at a certain stage of your illness to get palliative care. You can get it from the day of diagnosis. And if you are having unmanaged symptoms or anxiety or spiritual questions or whatever it may be that is causing you suffering, palliative care is indicated in that. So based on need, not on prognosis, and you can have it at any point from day of diagnosis to anywhere along the trajectory of your illness, and you can have it along with all your other treatments. So how well does the health system meet the needs of patients with chronic illness? We talked about all the sources of suffering, the physical sources of suffering, the anxiety and depression that inevitably affect almost 2/3 of people living with chronic illness, if not more. Our health system doesn't do a very good job of this. We're great at disease-targeted treatments, like, just even in eosinophilic disorder, some of the progress that's been made with biologics and other chemotherapeutic agents has changed a lot, and we do great with that. If it's technological advancement in disease targeted treatment, our health system does a really good job. But when it comes supporting people and really understanding how patients are experiencing the impact of their illness, we don't do a good job, because our gastroenterologists folks, the clinicians that work in that world, they focus on the gut. The cardiology people focus on the heart, the pulmonology people focus on the lungs, and that's the way we're trained in medical school. This isn't an indictment of my peers. This is just a reality of how we're taught, and sometimes we lack that full picture coordination of care that we really need to be able to live the best quality of life. And again, we're a sick care technology-driven system that shortchanges quality of life. In palliative care, we actually get trained to treat symptoms and distress and the whole person. But outside of that, like before I went into palliative care, I wasn't trained to treat pain or other distressing symptoms. We were trained to treat illness, not to treat the symptoms of the illness. So we need to do better about this. We need to treat the disease. We want people to maintain good function and quality of life. We need to help patients and families have coordinated and connected care, meaning my dad, when he was sick, he had kidney cancer. And when he was sick, he had about 6 or 7 doctors. And when I suggested to him that palliative care may help, he said, I don't need another doctor. I need just 2 of my doctors to talk to each other. Well, that's what he was talking about. He was talking about this care not being coordinated or connected. And so, patients want that. And patients and families want support to make informed decisions. So I don't know, as having been a doctor and a patient, I want to treat my disease. I want to live as long as possible, but I want to do so with a good quality of life. I want my doctors and other clinicians talking to each other, and I want somebody to help me make good decisions. And that's really what we all want. And this is where palliative care tries to address those things. We really focus on coordinating and making that all happen for a patient. So we do this by addressing the symptoms and stresses of the patient and the family. So again, just a note about caregivers, and I put these slides in because when we prepped for this webinar, we knew there'd be caregivers on the call, and I really, again, I mentioned they were the unsung heroes in people living with chronic disease, but the work they do and the impact it can have on people's health and well-being in such a negative way if they're not supported in a way that helps them as well. So, the exhaustion of doing this, and most caregivers are doing it with little to no training, and trying to work full-time jobs or even part-time jobs while being a full-time caregiver. It's really an enormous burden, and it causes a lot of distress. So we know that caregivers are often thrust into this position, don't have a lot of training, they have little support, and it ends up having an adverse effect on them physically, financially, socially, and even psychologically. So, we use the term caregiver burden. That term, it probably will change by the end of this call. I mean, we try to come up with language that captures the real essence of what it's like to be a caregiver and be so tired and crispy from doing the work of 2 or 3 people. It's really a term that I think doesn't do justice to the experience of it. And what we do know, though, is when caregivers do get tired and they get beat up, the association with sort of breakdowns in that caregiving is that hospital emergency department visits go up, nursing home placement happens, just basically a breakdown in care. So we're asking people who aren't trained, have little support, and have adverse physical, financial, social, and psychological outcomes on themselves doing the job they're doing, being the gatekeepers for keeping costs down and keeping people where they want to be. So it's a huge job, and we appreciate that. And we try to support the caregivers in palliative care as much as we can. I'm jumping around here. So what do the caregivers need? They want to be included in the care team. They want to be included in appointments and in conversations with the patient. And they want their information documented in the patient's record. Their health, well-being, capacity, and willingness to be a caregiver and any unmet needs should be addressed. When we see patients and their caregivers, we do care plans for both. The plans are meant to match the needs and reflect the goals of care for the patient first and foremost, but also for that caregiver. And caregiver needs should be addressed. And sometimes we refer to community-based services, appropriate services. Sometimes they have a chronic illness themselves that maybe is not as serious as the eosinophilic disorder that they're caregiving for. But we encourage them to seek medical consultation and facilitate that. Give them disease education resources, and then refer them to online and community resources as well. So some of the things that we can do, and we do in palliative care to help the caregiver, is include the caregiver as a member of the team and validate their contributions. Ask the caregiver about their health and well-being, not just the patient's, and address their needs. So, again, it doesn't take, these slides always seem so elementary to me, like, well, how big of a deal is it for a doc to look at a patient and say, you're doing a great job, tell me how things are going for you. But again, this is not something we're trained to do. We're not trained in communication skills, and we're not trained that our caregiving goes beyond the patient. So if this hasn't happened, if somebody hasn't asked you as a caregiver how you're doing, rather than being sort of angry about that or disappointed about it, I would say the people that maybe haven't done that for you just haven't been trained to. And if nothing else, I can speak for physicians only. I mean, we are trained through repetition to learn what we learn. And if this communication is not part of that repetition, it's probably not going to happen. It's just part of our training and the way we were trained. So, the other thing that comes up sometimes when I talk to my clinician colleagues is, well, I can't really talk to the caregiver because the caregiver is not my patient. Well, I guess technically, yes, they're not the patient, but the AMA supports that from a holistic and family-centered perspective. Clinicians are obligated to reach out to caregivers to assess their health and well-being. So not only should we be doing it, we are obligated to do it. And we know that if we support a caregiver, we can help avoid some of the things that everybody wants to avoid. Nobody wants to be in an emergency department. Nobody wants institutionalized, and nobody wants to be hospitalized. So sometimes that stuff's inevitable, but it shouldn't come from a breakdown in caregiving because we're not supporting caregivers. So, in palliative care, we address caregiver needs, we provide emotional support, we provide caregiver education information, and we get them help when we need to. So the goal of palliative care is really to help you achieve the best possible quality of life. And to do that, I think it really is these two things. We need to give you the best of cutting edge treatment and what medicine has to offer in terms of disease treatment. And that is what we do really well. Like in the US health system, we are great at this first part, right? We're coming up with new novel treatments every day, and we're doing an awesome job, like trying to treat the disease. Where we lack a little bit is in the second part, which is just as important. We need to do that with providing the best of what palliative care has to offer in terms of symptom management, quality of life. So yes, we need disease treatments. We want to live as long as possible, but we want to do it with the best quality of life that takes into account our full experience of the illness and its impact on us. So when we can do those two things, then we'll be on to something. So, you know, the impact of palliative care is to improve quality of life, to relieve those symptoms, to improve family support. By doing those three things on the left, we can accomplish the two on the right as I look at my screen, which is to reduce hospitalizations and emergency department visits and reduce unnecessary tests and procedures. One of the questions that may come up in the chat, but I'll just take it on here, is how do you pay for palliative care? Well, I'm a medical subspecialist like anybody else. So I would bill insurance. It's covered by all insurances. And even though we do it as a team, we don't bill as a team. We just bill under one provider. So you can imagine the reimbursement doesn't cover the expense of all the palliative care team, but most teams find a way to make that happen through support from a health system or some other source. So that's not something the patient or caregiver needs to worry about, but just know that it's a medical specialty that can bill just like the others. So the next bunch of slides is just a list of commonly asked questions. But Jennifer, what I want to do right now is maybe pause and see what questions we have from the folks on the call. And I'm not sure, it looks like there's a little action in the Q&A box, but not a whole lot. So
Absolutely, we can go ahead and ask some questions.
Okay.
So one of the questions that came in already is, what kind of criteria are there for getting on palliative care?
Well, again, this whole idea of it being based on need, not on prognosis. If you feel like your quality of life is not where you want it to be, if you're suffering in silence, one of the things I know from being a patient and a clinician is, and a caregiver at one point in my life was, you know, as patients, we don't normally tell people, our clinicians, the full breadth of the experience of what's going on with us. We usually paint a more rosy picture or are afraid to bring up all the sources of suffering we're experiencing. So I would just say, if you feel like your life is not where you'd like it to be, or if you're having unmanaged pain or anxiety or depression or something that maybe you haven't brought up to a provider before, those are all great reasons for referral to palliative care. One of the things I'll just sort of take head on is that, you know, some of your clinicians may not think palliative care is right. You may be suffering, but they'll say, well, it's too early for that, or you don't need that, because they'll make some association with hospice or something else, which is just not the reality. You know, palliative care can happen at anywhere in the disease progression, not based on prognosis. So, you know, there still are clinicians out there that, like patients and caregivers, don't fully understand what palliative care is. So you may have to advocate a little stronger for yourself, but I would just say, if your quality of life's not where you want it to be, or you have unmanaged symptoms, I think that's a great spot to get palliative care involved.
Follow up, could you give some examples of the types of symptoms that people should be considering? Like, if their doctor's not recommending palliative care, what type of symptoms could people advocate for it on their own?
Yeah, well, I would think, you know, with the group on this call, you know, I mean, that's why I wanted the polling question. I mean, the pain and fatigue, the gastric symptoms that happen. I mean, I think any of those would be a trigger for it. I think the physical symptoms are always the easiest ones to point to, right? If somebody's short of breath, or somebody's malnourished, or having trouble with their GI system and really food restricted, or having pain, aches and, you know, joint pain, you know, those are simple to say, like, okay, this is happening, I can use palliative care. The ones that really suffer in silence to me are people that have anxiety, depression, and some of the psychiatric stuff that goes along with chronic illness. And I would say that, if that's something you're experiencing, palliative care can be a huge help to you in that, because, our organ targeted way that our specialties are set up, our heart doctors deal with the heart, our lung doctors deal with the lung, they're not trained in a way to recognize and screen for depression, anxiety, and those things. And patients very rarely come out and say it. So, if you're just feeling down, or some of that fatigue may be depression or anxiety, those are reasons to get screened for palliative care as well. I know that's kind of a rambling answer, but I hope I connected on it.
No, I appreciate it. And so another follow-up that's come in, if you're interested in palliative care, do you have to go through your doctor? Is there an organization or a group or something that you reach out to directly on your own? How do you get palliative care?
Yeah, so we need to be, we need to have patients referred to us. So that referral would come from your primary care doc, or if you're seeing hematology or gastroenterology, or any doc can make that referral. I would say if you're in between doc visits, and you still think it could be helpful, there is a website called getpalliativecare.org. I'll try to pull that up and not screw things up too bad with the screen right now. But getpalliativecare.org is a great website to go to find where palliative care is located in your area. And I'm having trouble finding it. I'm just going to close out of this. I'll try again in a second, but getpalliativecare.org, they will have a list of palliative care programs in your area, a list of what to ask your doctor. So at your next appointment, you can actually download a list of questions to ask one of your current providers about palliative care, and help get the referral that way. And thank you for putting the link in that.
Absolutely. We're getting some more specific questions as well. Was there more of your presentation that you wanted to give, or should we?
No, this is really what I was hoping to do, is to do this.
Wonderful. So we've got an individual who has had chronic eosinophilic pneumonia. She was diagnosed in 1989, and she's been on prednisone and been supplementing with other biologics. And she has a hard time figuring out how much to push her body to do, because of the balance of fatigue and feeling worse when pushing. As a palliative care professional, how do you recommend balancing productivity with rest?
Great question. Fatigue is one of it spans the breadth of almost all chronic illness, because just by the fact that the illness you're experiencing is chronic, that it's it is a fatiguing thing to wake up every day and have to deal with it. So we deal a lot with this, and one of the ways we really work at addressing the fatigue and striking this balance between productivity or activity and rest is to first get to know our patients in a way that we really understand what's most important to them. And so by asking a lot of questions, and more importantly, doing a lot of listening, finding out what are the things that are most important to you in your life that you want to have the energy to do, and then coming up with strategies to make sure that you have the energy to do those. Again, this is about quality of life. So what is important to you? So, on our Get Palliative Care website that's up here, if you go to your specific disease on this, you'll see, I'll pull this up. This is a podcast with a patient named Allie, who described being a student at the University of Iowa. And what she would do is, fatigue was a big part of what she was experiencing, but she was also a real high achiever, honor society in high school and all these things. So she would start a semester by taking a full load of classes and realize halfway through that she couldn't do it, and she'd end up dropping them. And that really affected her emotionally, because she felt like, she was letting herself down, not succeeding and things like that. But when she started working with palliative care, they came up with a strategy where she would sign up for just maybe 1 or 2 classes, maybe 3 or 5, 6 credit hours, and take on a workload that was more doable. So not only was she able to continue with her studies, but she didn't have that emotional impact of feeling like she failed at something. So it's maybe subtle and nuanced, but I think what I'm trying to say is that it really depends on what's most important to you, and then working with the palliative care team to develop strategies to manage symptoms more aggressively right before you're going to do something active, or schedule rest so that you have more energy to do something when you want to do it. But we can't know what those things are in a blanket way. It's really individualized to what's important with patients, or what's important to the patients.
Balance sounds like that key word there, figuring out the
Yeah.
give and take.
Yeah.
On the flip side, in addition to the patients having challenges with balances and fatigue and so forth, we've got another question about advice for caregivers. So someone's husband is really great about logistics and taking care of picking up prescriptions and driving to appointments and doing household chores, but they're so exhausted from doing all of that that they don't find like they're getting a lot of tenderness or sympathy from their caregiver. Do you have any advice?
Well, it's a guy thing for sure. I mean, we're great with acts of service, sometimes at the expense of acts of kindness. And so, part of this is how we're genetically programmed. But I think the first step is just having this conversation, just naming it. And then again, how I would approach this with a palliative care team I would have myself and the social worker sit down with this couple and say, okay, like, what are the things that absolutely need to be done by the husband, and what are the things that there's community resources to help out with, or church groups, or somebody else that could come in the house and take some of that burden off to allow the couple just to be husband and wife. And so I think again, it's individualized, but it takes sitting down and listening to our patients and caregivers to really get to the bottom of it and find out how to do that. Is that specific enough of an answer, or do they want me to go a little further?
I think it's very helpful. If you have follow-up questions and you ask that question, please feel free to type those out. You've talked a lot about what palliative care can do, where people can find resources about it. How does it work in terms of paying for it? Is it covered under insurance?
Yeah, it's insurance pays for it. So, if somebody comes to, my clinic, we have, I'm a little bit lucky. I have psychiatrists in the clinic with me, social work, nursing. And so how it would happen is you'd get referred to me, and I would bill your insurance just like any other provider you got referred to, whether you're seeing a gastroenterologist or a hematologist, whoever it may be. And that bill would get submitted to your insurance. Now, it wouldn't cover the cost of my social worker or the nurse or the other folks in our clinic, but we have support from a local health system that helps us offset some of that expense. So for the patient and family, it's just a doctor's charge to their insurance like anything else. There's co-pays associated with how you see physicians or nurse practitioners that would apply to us as well, but it's billed through insurance. So shortest, most direct answer.
You talked about working with a team to be able to treat people. What type of clinicians are involved in palliative care?
Yeah. So because of the last question, how it's paid for, like, we do bill for our services, but as it doesn't cover the whole team, it's really just reimbursing one person in that team for their time. So, some places are limited with the kind of staffing they can have. So not all palliative care teams are going to look the same across the country. Some places are going to have the core team that the profession was built on is physician, nursing, social work, chaplain. And we sort of hold that as the standard palliative care team. Some places will have that, some places will have less, some places will have more, some places will have pharmacists, nurse navigators, all kinds of things. Acupuncture, I worked in a place where we had acupuncture. I mean, we just had incredible resources in one of my sites because we had a lot of philanthropy support. But so there will be some variability, but the core that most places have is nursing, social work, and physician, and then with access to chaplain services in some way. So yeah, but I will I wouldn't be being totally forthcoming if I didn't say that may not be what you find in your area. It's not what everybody's going to find everywhere.
Are palliative care generally through like large multidisciplinary care centers, or are they private practices?
Yeah, so they're in, over 80% of all US hospitals, no matter what size now. So yes, in the big medical centers and in most hospitals, you're going to find palliative care. In the community, it gets a little bit more spotty. It's one of the things we work on in the Center to Advance Palliative Care is what do we do to support community-based palliative care programs? And so they grow, and they are growing, and they're growing rapidly. So not all are in the academic medical centers or in hospitals. A lot are, but there are more and more community programs popping up all the time. And what I always tell patients and families is if you go on the getpalliativecare.org site and you don't find a community-based palliative care program in your community, but you see a hospital one, I give them a call. And when I talk to those programs, I always say like, hey, if you get a call from a patient asking about community palliative care, talk to them, get them to resources. So most palliative care people are pretty generous with their time. And so if you call and say like, hey, I'm not in the hospital, but I would like to know if there's any palliative care that you know of in the area, they usually are pretty helpful with that. And
Right.
I'll share my email too. If you ever have a question, I'll put my email in the chat box, and then you can reach out to me, and I'll do some investigating to see who's in your area.
Thank you. So you've talked a lot about, I think your comment here leads nicely into another question that came in. So we've been talking about how people outside of the hospital can get care, but we also have some people who sometimes are hospitalized or they're in the ICU for some reason. Does palliative care play a role for inpatient care in a hospital?
Yeah, there's a lot of that's probably where most patients with chronic illness end up getting engaged with palliative care for the first time. Is they've had a crisis or they've had something break down, or a symptom flare up, and they end up hospitalized, and palliative care gets involved at that time and then ends up following them as an outpatient. So like I said, the majority of hospitals in the country have palliative care, and so getting that referral in the hospital is actually pretty common.
Great. Let's see. So if someone has a chronic illness and they're having trouble getting their friends or family to understand, because it's not something that's extremely visible, do you have any advice for helping to communicate with other people about what it's like to live with a chronic illness?
Such a good question. I want to make sure I give a thoughtful answer to it.
Certainly, the individual has kind of shared that they don't want to always complain or talk about their illness all the time, but it's difficult because their life revolves around it. It's a part of them, it's not all of them, but it's hard sometimes to share that information.
This one hits home for me, which is probably why I'm stammering so much. When you get diagnosed with a serious illness, for me, it was melanoma. For my first wife who passed away, she had lymphoma. It becomes your identity if you let it, right? Like you become that patient with lymphoma, or within your social circle, you become, oh, well, Andy's sick or Lori's sick. Like you sort of lose that identity. Like you're no longer a pharmacist like my first wife was, or a physician. You become your diagnosis. And so I would say what helped me the most was striking that balance of when I'm hurting and I couldn't do something socially, I would say like, hey, I'm just not up for it tonight because I'm just feeling sick from treatment or whatever it was, but not dwelling on it, like not making it the focal point of the conversation. But then other times when I was able to engage socially, to just do that and try to be as, not make what I was living through or my experience be the focal point of the night. So there is some effort that patients can put in. There's also a reality to face that, some people will really sort of stand up and get it and support you and be there for you. And then there will be some that will fall off. And I don't know. I don't know the magic for having that not happen. I think that may just be part of human nature. But I do think what it taught me anyway was to really cherish the people that hung in there with me and I could be myself with, that I could say, hey, I'm having a bad day, not today, but then also go and have fun and have a good day with them. It just made me value those relationships more. And those are the people that I'm still, the closest with moving on. I always worry when questions hit home like that on a personal level that I don't answer them clearly, because I get all my own stuff mixed up in there and don't know if I answer the question. So if I didn't do that adequately, just come back at me again in the question box and I'll try again.
We certainly appreciate you sharing some of your personal experiences to help other people be able to relate and deal with their own.
Yeah.
So your team shared with me a quiz, and I'm curious if you could share a little bit more about that with our participants today. Understand there's an interactive quiz to help people decide whether palliative care might be right for you or your loved one.
Oh, did they find that on the Get Palliative Care website?
Yes.
Yeah. So let me see if I can pull it up again. Now you're going to embarrass me because I'm not going to know where to find it. Probably in the, is it right for you? Yes. So the idea behind this is that, well, it really doesn't apply to this group because 2/3 of you knew what palliative care was or had some idea. So for most people, and in years past, like people really didn't know what it was. So what we try to do is create this quiz to just say, basically, do you have a serious illness? Are you having symptoms that are impacting the quality of your life? Are you having, sometimes people don't know what a symptom is, like they don't see themselves as being anxious or depressed or having lack of appetite. But so yeah, answer that question a different way. Has somebody or someone close to you, have you or somebody close to you experienced any of the following? And we sort of get at the common symptoms or sources of suffering. People that are bouncing in and out of the emergency room a lot usually aren't having a very good quality of life if they're having to go back and forth so much. And then just really talking about like, what do you need help with? I use that word a lot. And so this quiz is really meant to draw your attention to the fact that you may not be living the best quality of life that you can, and that palliative care would be right for you, because we tend to suffer in silence, we tend to internalize, and we tend to put our best face forward when we go to see our clinicians. Not uncommon for me to have, especially on initial visits, my patients will have makeup on and they'll be dressed up and they'll try to, it's almost like they don't want to disappoint their clinicians. They want to look like they're doing good. And as I get to know them more and we build more of a trusting relationship, I start to see more of the real them. A lot of times it's pajama pants and you can see they're suffering and they're hurting and we got to get to work and address something. So I would say, this is really just about drawing your awareness to maybe things could be better than how you're experiencing them right now.
Okay. So there have been a lot of changes to the medical system over the last few years as a result of the pandemic, and there's been an increase of telemedicine. Is there a role for telemedicine in palliative care services, and have palliative care services changed as a result of the pandemic?
Great two questions. I'll take telehealth in a silo first. Yes, palliative care teams have embraced telemedicine, especially to reach people that were in the community that did not want to be coming into offices and being exposed to whatever might be there. And the government has made it so that we can continue to be doing telemedicine and billing for it and providing that level for patients and families. Is it perfect? It's not. That human connection is a big part of what we do. Body language and sort of the dynamics in a room, I don't really get on a screen that I would get if I was having a family meeting or talking to a patient and caregiver in a room, but it's better than not seeing them at all. And sometimes that was the alternative, especially in the darker days of the pandemic. Not that these are exactly bright, but I do think at one point they were worse. And so telemedicine is helpful in that way, that it allows us to get some people that we wouldn't normally. It's also allowed us to expand our scope. So if anybody on this call lives in a rural area where maybe palliative care isn't around the corner, it gives us access to see people that are normally would not be able to make a trip an hour and a half, 2 hours into an office. So I think the pros have outweighed the cons. I think most palliative care programs that I talk to describe doing a mix of inpatient and telemedicine. Those visits where we're talking about sensitive subjects like disease trajectory and maybe depression or anxiety symptoms, sometimes those need to be done in person. But then the follow-up, hey, how are the meds going? Are you tolerating it okay? That could be a Zoom call, right? Or a DoxyMe call, or whatever platform your clinicians are using. So I think palliative care in the future will be a mix of both, and I think it'll work really well. The second part of the question is a little more complicated. How has the pandemic affected palliative care? So one of the things that has happened to palliative care teams is they've gotten a lot more busy because of the way COVID hit in such a fierce way and affected our patient population. The people with chronic illnesses were the ones, especially early on, that were really being devastated by COVID, and were the ones that were really succumbing to the illness. So it really hit our patient population in a way that was profound. And so we got busier. And then what's happened is there's been this recognition from our colleagues that, hey, we're pretty helpful when people have like lingering symptoms post-COVID, or hey, we're just really good communicating with people about illness and goals of care and what's important to them. And so we're getting more referrals from colleagues for other illnesses that aren't COVID related because of the way we were able to perform and meet needs during the heights or different surges in the pandemic. So it's been, depends on how you want to look at it. It's either been good for the field because it's grown the field and it's increased awareness of what we can do and how we can help. It's also made us a lot busier at a time where people are short-staffed and we have people on FMLA because they're ill or are caring for somebody who had COVID. So there's that reality cuts both ways, but I think overall it's a good thing because I'm starting to see more of a philosophical shift from let's just treat this particular thing about you and get you out of the hospital to, hey, maybe we ought to get palliative care involved and really see what's going on with the whole patient. And so I think that philosophical switch to being worried about you and your caregivers is a good one.
Looking at the whole picture is always a good idea.
Yeah.
Absolutely. So for those that can't access palliative care even via telemed, are there any resources that can help people on their own at home?
Yeah, I think the getpalliativecare.org site is great. I think you're going to find probably 80 to 90% of what you would want to find there. It talks about the specific illnesses, talks about, there's a lot of great like little podcast, video clips, sound clips, things like that, where you can actually hear what other people's experience was with it. The other thing that you can do is, the site gives you a list of questions to ask your clinician. So even if you can't get to palliative care, how to advocate for yourself, how to communicate, like how this is how I'm feeling, and not be dismissed. Because one of the things I'm just going to use myself because I don't want to throw any other clinician under the bus, but early in my career, because of the way I was trained, it's easy to dismiss somebody when they come to see you and they're on your schedule because they're having, this is before I did palliative care and I was doing internal medicine, like they're having abdominal pain. Well, if it starts veering off into I'm having abdominal pains, but I'm having marital problems because the pain's affecting our intimacy. And like, if it starts going down that road, I would get it back on track quick and I wouldn't let it go there. But when you're living with a serious illness, when you're living with anything that's impacting your quality of life, all those things need to be explored for you to really do as well as you can. And so I think using the getpalliativecare.org site to practice the language to make sure that you engage your clinicians in what the experience is like for you so that they can address it. Even if they can't get you to specialty palliative care, there's still a lot they can do.
good that there's so many different options. When somebody with a chronic illness is trying to, again, come back to balance, which we talked about earlier, of how much they put into the work that they're doing versus balancing being able to still take care of themselves and make a living. Do you have any comments or suggestions for the types of things they can do to make sure that they're able to relatively do both?
Yeah. First thing I would do is make sure, is this caregivers or patients, or could be either?
The question came from a patient.
Patient.
Yes.
So first and foremost, and you're probably already doing this, but make sure you're maximizing your disease-directed treatment. Make sure that you're not missing appointments, and you're doing follow-ups, and you're asking questions about, is there any other treatment for me out there that may help target the disease, which in turn would give me more energy and maybe improve my quality of life. The second thing I would do is, if you can engage with palliative care, or if you have a clinician that you have a really strong bond with, do an honest assessment of where you're at, symptom-wise and emotionally and psychologically. Like, a lot of undiagnosed depression, anxiety, things that are super fatiguing. Some people have a lot of spiritual angst, like, why did this happen to me? There's all these things that go in. In palliative care, we talk about something called total pain. And by total pain, we mean it's not just the physical, it's what's happening emotionally, what's happening financially, what's happening, all these other aspects of your life that are fatiguing and impact your experience of the illness. So we always say not all pain is physical. Well, not all fatigue is due to your eosinophilic disease. Some of your fatigue could be due to emotionally the toll it's taken on you. So a full comprehensive assessment of where you're at psychiatrically, socially, financially, looking at all those components in a 360 to make sure that we can pinpoint what are the things that are sapping your energy in addition to your disease. And then once that's all done, then you sit down and you develop a plan to, okay, how are these things that are sapping your energy? How are we going to address those? And let's do that, whether it's disease targeted treatment, whether it's, let's get you financial advice or help you need, like, let's link you to community resources. Let's treat your anxiety that's undiagnosed, or your depression that's undiagnosed, and get you as good as we can get you physically. And then we talk about, energy conservation and timing your activities and things like that. So it all starts with comprehensive assessment. And by comprehensive assessment, I mean, there's an obligation of your clinician to really dive deep to get the full experience of what's happening. And you have some of that responsibility too, to give them honest answers. If somebody's willing to go down that road with you, please go down that road, because you can feel a whole lot better when you give somebody a full picture of what it's like in your life day to day.
So we've got another question here about, how does case management differ from palliative care?
I'm sorry, one more time. I was reading the chat box and
Sure. How does case management differ from palliative care?
Yeah, this is a really good question. And I almost wonder if the person asking is a social worker or a nurse that does case management, because the lines do get blurred, especially in hospitals. But case management generally, and I'm going to tiptoe here because I'm not a case manager. I don't want to speak out of turn here, but case management, from my perspective as a physician who has worked with them, they're pretty targeted. They're looking at how to link to community resources, how to do placement if that's needed, like really sort of the functional nuts and bolts of what does this person need to be able to get to the next place that they're going, whether that's from in the hospital to out of the hospital, or from in their home to doing better in the home because they need different services. It's sort of really targeted on action. A palliative care social worker will also do some of that work, but really they're focusing on your experience of the disease as a person, what's happening to you socially, psychologically, like that. So it's more of an assessment of the emotional impact than it is sort of the what chores or what things do I need to do to make your life better. It's a little bit of that, but it's how is this affecting you and what can I do to address that as well?
Another question come in about what you can look for in your children when it comes to pain. So I'm a dad parent of a 2-year-old EOE, and it's brand new to us. What are some of the things we should be looking for in our child if he can't tell us what's going on? Is there anything we need to know or can see signs of pain that they can't explain to us?
Yeah. I mean, the sort of non-physical indicators of pain, and I will confess I don't do pediatrics. You know, I'm an adult palliative care doc in internal medicine, but you know, not being consolable is always a big one. You know, not being able to calm a child down. You know, with being withdrawn is another thing I would explore. And I would really, you know, anything that seems out of the ordinary, which may be hard because the child's been living with the illness probably from the beginning, but anything that seems out of the ordinary, I would just make the call to whoever the main provider you have is and just say, like, you know, I'm worried that this may be pain. My child is doing this. I mean, the stakes are so high. I just think, especially if you get involved with a pediatric palliative care program, they'll want those calls, and I would make them regularly, because it is hard to tell when somebody can't verbalize what's happening. So, and people express things in very different ways. Like, again, an inconsolable child who's screaming nonstop, that might be more easy to recognize than someone who's just withdrawn and quiet. So either are concerning to me.
Thank you for your wonderful presentation and for your thoughtful answers. And also to thank everyone who attended today for all of the questions that you put in. We really had such a wonderful, lengthy question and answer discussion today. And I really hope that it was valuable to everyone who joined us. I also want to thank our education partners for their support of this webinar series, including AstraZeneca, Bristol Myers Squibb, and Takeda. Our next webinar is scheduled for February 24th at 12:00 p.m. Carrie Devlin from Johns Hopkins Center for Music and Medicine will be joining us to discuss music therapy for chronic disease. She's going to share what music therapy entails, how it can help with chronic illness, and how to find music therapy programs. Registration is now open on our website at apfed.org/webinars. So we hope you will check it out and register to join us. If you'd like to continue the discussion that started today, we also encourage you to join our online community on the Inspire Network. It's a great place to connect with patients and caregivers for support. You can visit apfed.org/connections to be able to join the discussion. If you'd like to continue learning even more about eosinophil-associated diseases, we also encourage you to subscribe and listen to our podcast, Real Talk Eosinophilic Diseases. Our latest episode came out this morning. It's featuring Dr. Jerry Gleich, who is a longtime researcher of eosinophils, and he really walks us through the history. Our co-hosts Ryan Piansky and Beth Allen had a wonderful discussion with Dr. Gleich. You can find it on our website at apfed.org/podcast. You can also subscribe and listen on Apple Podcasts, Spotify, Audible, and more. If you enjoyed today's webinar and are interested in watching more presentations, in addition to watching the webinar recordings on our website, we also encourage you to check out our annual conference, EOS Connection. In 2021, we held the conference virtually, and all the sessions are still available on demand. You can even still access the exhibit hall and the research hall. Registration is free for the conference, and hint, hint, APFED membership is free as well. There are paid memberships, and we always appreciate your donations, but you can get into this conference for free. So please visit apfed.org/conference to check out all the wonderful resources. So once again, thank you all for joining us for APFED's EOS Support Webinar Series, and to Dr. Esch for a wonderful presentation. If anyone has any further questions, please feel free to follow up with us at mail@apfed.org. Have a great day.